Welcome to Chronic Choices Critical Voices, a discussion series that brings together diverse perspectives on health, policy, and the lived experiences of millions of Americans managing one or more chronic conditions. I'm Candace DeMatteis, Vice President of Policy for the Partnership to Fight Chronic Disease. In this discussion series, we are talking with important stakeholders across the healthcare continuum. They know that innovation, coverage, and access are all critical components of improving overall health outcomes for people living with chronic conditions. Today, I'm happy to welcome Dr. Michael C. Burgess. Prior to being entrusted with representing the people of the 26th District of Texas in the U.S. House of Representatives, Congressman Mike Burgess practiced medicine as an obstetrician for 30 years. Dr. Burgess served on House Energy and Commerce Committee as the chairman of the Subcommittee on Commerce, Manufacturing, and Trade, in addition to sitting on the Subcommittee on Health and the Subcommittee on Oversight and Investigations. Dr. Burgess also founded and co-chaired the Congressional Health Caucus and was a leader of the influential Doctors Caucus as well. His medical background and experience provide him a unique perspective on health policy and legislation affecting healthcare. Dr. Burgess's commitment to protecting patients' rights and raising the bar for our standard of care can be seen in his efforts to expand care options for patients, to sensibly reform liability laws, to protect patients' rights, and to ensure that we are educating enough doctors to provide proper care for civilians and veterans alike. Dr. Burgess, thank you so much for joining me today. Let's dig right in. How do you see the government impose price mandates influencing formulary design, particularly the risk that health plans may restrict access to certain therapies or delay coverage decisions for patients who are dealing with complex chronic conditions and who may not respond well to the first line treatments that formularies require people to try first and fail on?
Yeah, that's been a concern of mine for some time. First off, let me just tell you, I'm not a fan of price controls. I grew up in the 1970s. I was a resident at Parkland Hospital, and I remember finishing a long shift and having to stop for gas because it was my day to buy gas,
Mm.
and the lines were so long, and how dispiriting that was to have to go through that. But that's what price controls get you. They get you lack of access, lots of waiting lines. And look, if your goal as a policymaker is we just want to spend less money, maybe that will achieve your goal. But if you're a patient who is depending upon something and having to wait for it or having to file several appeals, then you don't get it. And what we always say is care delayed is care denied. And unfortunately, with some conditions, that's drastically true.
It's an interesting anecdote you raise, and I remember it. It was based, as I recall, on your license plate number, whether it was
Yes.
even or odd, which day you got to fill up your tank. And it's just something that many people didn't experience and maybe not have that reference. But can you imagine a patient? Is it diabetes day or cardiovascular? Or I mean, that's really scary when you put it in those kind of terms.
Well, and formularies as well. I mean, I know, I lived in the policymaker world for a couple of decades. I lived in the practice world for a couple of decades. Formularies sound good sometimes. Look, let's just get the best price we can, and then that's what everyone will take. But look, one size fits all is not a thing in patient world because
Mm.
patients come in all shapes and sizes. They have all kinds of needs, and being consigned to a formulary. Well, look, the VA, people will sometimes say the VA is great because they can hold prices down, they can hold costs down with a formulary. But practicing at a VA, you had limited choices in what you were able to provide your patient. And there would be times you would say, look, I'm writing you this prescription, go get it filled somewhere else. And because this is what you need.
But the nice thing is they had that option, I guess, to get it
Yes.
somewhere
Right.
else.
That would be that the expense would be on them. And you see the same thing today in some of the prior authorization and the what do you call them? The fail first
Mhm.
schemes that are out there. It's it's not from a physician standpoint is not a satisfactory way to practice medicine. If you're a doc who has a patient who has asthma and you know that one medicine works better for them than any of the others, and then they change insurance and they say, well, we'd like you to go back to the older established treatments before we go to this. No, they've been on it, they're stable. Don't change it now. And don't make the patient jump through all kinds of hoops to be able to get the medicine they need. And don't make the doc have to make multiple phone calls in order to get the patient the medicine they need.
Yeah, it's a lot of time, I know, on the physician's part. I want to talk a little bit more about that one size fits all. And we know that a lot of the pricing, drug pricing discussions today are comparing us to other countries. And countries that use centralized price setting often rely on population level metrics like the quality adjusted life year to determine whether they're going to cover it and at what price. So, how well do those models capture the lived reality of individuals managing oftentimes multiple chronic conditions? And what risks arise when those metrics are driving coverage decisions here in the US, where we have a much more heterogeneous population, for example, with different health status?
Well, there's two very important points in that question. One, of course, is that you want to be careful about importing other countries' price controls. Um, and do bear in mind that other countries have significantly different systems. Boy, this really kind of came to light in all the vaccine discussion a few months ago, where the statement was made, well, Denmark only has 10 vaccines, so we should be more like Denmark. And then it was pointed out, well, wait a minute, Denmark has an entirely different system. They have a high tax system, but it's low cost to the patient. And it is an entirely different world that a Danish family lives in than what an American family lives in. On the other hand, the ability to get newer cutting edge treatments is vastly improved in the United States. So is that a trade-off that you're willing to make? Now, the quality adjusted life year, that was the brainchild of Dr. Ezekiel Emanuel, who was one of the proponents of the Affordable Care Act. And the concept there was if someone's in perfect health, then we assign them a value of one. But if someone is in less than perfect health, their adjusted life year is assigned a lower number. Now, again, if you're in another country where they've got price controls, that may make sense, but it doesn't make sense in our system. And the end result is that someone who has perhaps a greater need is likely to be denied because their quality adjusted life year score is adjusted downward. It's lower. So, well, here is a person in their 70s, and we're having to make a decision about a renal pharmaceutical, something to help kidney function. But realistically, how many years they got left? So we'll we'll assign them a lower value in this system. Well, bear in mind that other countries do use that. It's an anathema to a free society like America. I can just imagine the doctor having to have that discussion. Patients aren't going to accept that. But in other countries, they do have that. And when you re-import their price controls along with their prices, you're actually going to be opening the door. And people with disabilities, people who have harsh diagnoses, they are the ones, not that just that they're going to be inconvenienced, but they're going to be harmed. And look, if that's the direction policymakers want to go, they need to do the hard work, they need to do the hearings, and they need to have the full information at hand before they make these types of decisions. Otherwise, in our system, our political system, they're going to be punished by their constituents, and rightly so, because at the end of the day, it's not the agency that's responsible. It is the member of Congress who writes the rules that the agency functions under. So that's, again, something that's sometimes lost on policymakers. Ultimately, this is your decision, and it is going to come back to you if there are constituents, your patients in your district, patients in your state, your constituents are inconvenienced or harmed by this, they or their families are the ones who are going to hold you responsible politically. And that's the way it should be.
No, you raised many great points there. And as you stated, in systems with very strict price controls, which is what we're comparing, or these foreign price controls we're comparing to US prices, they often experience delays in access to new therapies. The US is usually the first market to get them. We have the clinical trials here. So even before they come to market, and that's because of our free market system. So, what are some of the downstream consequences that you're concerned about for patients with progressive chronic diseases when early intervention is delayed, not just clinically delayed, maybe they don't get in or have access for diagnosis, but in terms of also the long-term healthcare costs and quality of life if they don't have that early access that we have enjoyed historically?
Yeah, and it's a real problem, and for some patient groups, it's an enormous problem, and this is why President Trump, when he signed the right to try legislation in his first term, that was enormously popular. And I'll never forget the room when he had that bill signing. And of course, you had patients with ALS, you had patients with Duchenne muscular dystrophy who knew there were therapies, but they weren't quite available to them
Mhm.
yet. And look, if you're a young person with muscular dystrophy, every year that you lose function is function you're not going to get back. So if there's something that can perhaps put the brakes on that loss, it's something you want to get started on right away. Well, fortunately, in the United States, you generally have earlier access to these medicines, and the whole purpose of Right to Try was, and can you even make that access quicker? Uh, but going another direction and saying, let's make that quick access harder or non-existent, it's really going to harm some patient populations. And again, the stories I heard from families with kids with muscular dystrophy were probably some of the most striking because they had they looked at a situation where perhaps they had made some improvement, but they were going to lose access because of whatever reason, whatever bureaucratic reason, and their lives were going to be significantly diminished because of those decisions. Well, Right to Try gave them the freedom to pursue the treatments that they knew were going to be in their best interest and not have to wait for the bureaucracy to catch up. But that could be far worse if you're importing these types of drug controls from other countries. You might not even ever have that chance. And clinical trials, a lot of people forget about clinical trials. We used to hear over and over again in Congress, hey, the NIH is funding this research and it's not the drug companies, they're just getting the profits. Well, wait a minute. The NIH may do the basic research. They may get something going in a phase 1 trial, but phase 2 and phase 3 clinical trials are enormously expensive. They take a long time for each new drug. It's about $1 billion or $1.5 billion, and it's about 10 to 14 years in development. That's a significant time investment. And the other thing is, there are more often than not, any one of those compounds may not make it through the process. So, as we say in Texas, you're drilling a lot of dry holes to get one that pays off. And that's the reality that companies in the United States, the way the system is formatted, they're willing to take those risks. But if you remove that, um, it is going to be it is going to have a chilling effect on new drug development. There just won't be the reason why you would make that investment in the first place if you're only going to be hit on the other side with a third country's price controls.
No, all great points. I wonder too, with the how increased government involvement in drug pricing and value determinations, how that might affect a physician's ability to tailor treatments to individual patients, especially those with comorbidities or an atypical disease progression that don't necessarily align with standardized treatment pathways. Have you experienced that, and or do you have concerns in that area as well?
Well, every doctor knows that a drug that's approved by the FDA for a certain condition, you can you can use that off-label for another condition if you've found that to be helpful. And that is, I mean, that's just something that happens daily in a physician's practice so frequently that they don't even really think about it. But if there were very restrictive rules and parameters placed upon that, physicians would lose a lot of latitude. And it's not just latitude that, hey, it's great for the doctor that they have the ability to make these choices. It's harmful to the patient that they are not going to have what a doctor's best training and experience tells them. This is what you need. Yes, the FDA indication is perhaps different, but in my experience, this works well. And this is something I think you should be willing to try. And patients most of the time will accept that advice and do that. Unfortunately, if you restrict that harshly, it's going to eliminate therapies that might otherwise be available.
Dr. Burgess, I know when you were in Congress, the IRA passed, which had Medicare drug pricing program as part of that. And many people pushed back on that as drug price controls and kind of the first, I guess, step toward more government control in that market. And as a policymaker, you rely on Medicare actuaries, the CBO, to kind of help you understand what the downstream implications are. Are there, how was your experience with that? And do you have any insights that you could share with current members of Congress who may be looking at this and trying to figure out what the implications are and how reliable those estimates are in terms of their impact on innovation, costs, et cetera?
Well, let me just back up a little bit and say when the Democrats proposed this, and they proposed it actually in Trump's first administration in 2019, and then they eventually, when they had a president who would sign it, President Biden, and they had majorities in the House and the Senate, they passed it under reconciliation. And the idea was, okay, Part D Medicare, the so-called non-interference clause, the secretary cannot negotiate drug prices. And the reality is the negotiation on drug prices occurs with the PBMs. I mean, they're the ones who are able to do that. They have the financial clout, but they wanted the government to be able to do that. But here's the thing. It wasn't actually a negotiation. It was a hostage taking. The way the law was written was that if a company produces a new drug and their launch price is something that a bureaucrat at HHS says, hmm, not good, not to our liking. We'd like something vastly different. There isn't a negotiation. What there is a punitive tax that is levied on that company, uh, and it's a gross receipts tax. It's not a net tax. So a gross receipts tax is levied on that company if they do not comply with the government's wishes. Well, we like to point out that that's not a negotiation, that's a hostage taking, and it appears they're willing to shoot the hostage. Uh, so fast forward to where we are now, and through the remainder of the Biden administration, and even during the Trump administration, the rules are being written. If you literally got to keep up with the Federal Register on a daily basis to see where this is going to end up. But think of a massive uh, federal government controlled PBM where there is no relief, there is no escape. Once that happens, it happens. You may drive companies offshore from the United States. That would be a bad thing. In fact, that kind of happened in the 90s with medical devices, where it became very hostile in this country to try to get a device approved through the FDA, and they went offshore to get the devices approved. And then, of course, another country is going to say, if we're approving it for you, we'd like to have the manufacture done in our country, not in your country. And so you ended up offshoring a lot of that. And again, just those are results, unintended results that people need to bear in mind. If I were still in the legislative branch, which I am not, uh, this is on you, Congress. You're the one, number one, you passed that law, even though you can say, well, it was the other party that did it. I didn't have anything to do with that. I voted against it. I mean, I would make that argument if I was still there. However, it is on you, the current members of Congress. You've got to have the oversight. The agency is not, that has now been given this power, is not going to come in someday and say, you know what, you really overstepped here. We shouldn't have this much power, so we'd like for you to take some of it back. No, you've got to do that through the oversight hearings. Sometimes they can be contentious. You've got to be prepared. Your staff has to do a good job about preparing you for the types of oversight to be done. And it's not just gotcha questions, but you've got to really dig into this stuff and be certain that you understand. So that's what my recommendation to current members of Congress is you need to continually take a look at this stuff. Things don't end at the signing ceremony where everybody gets a pen and goes home happy. Then the agency takes over. They write the rules, and the rules, unfortunately, are what your constituents have to live under. And they need you, members of Congress, to be vigilant about reassessing those as the rules come out of the agency and making certain that they don't go in a direction in which you didn't intend. I could give you example after example of that, but it is really Congress which has they got the power, they've got subpoena power. They can invite any agency head in or subhead in, ask them the hard questions, ask them to provide the data. And that's the type of oversight or what I would even use to term monitoring of existing law that needs to occur. But if you don't do that, then the agency is quite happy to take the power that you gave them. And if it inconveniences your constituents, that doesn't bother them. If it harms your constituents, well, that cost of doing business will be okay. No, it is the legislator's job to oversee that and to be certain. Look, there's a lot of chutzpah in Congress. I think we'd all agree on that. But think of it, you're going to do a major piece of legislation that is really going to change things for your constituents in significant ways. Do you really think you got it right when you passed it? Or might you have to come back and look at it and make adjustments? And this was always my argument on the Affordable Care Act, my argument on the No Surprises Act. Things evolve and may change, and you may not have gotten every part of it right when you went to the, again, said signing ceremony and everyone felt good about it. You've got to stay with it. You've got to continue to assess and evaluate. Listen to your constituents who will bring you the information that you otherwise may not have had when you cast that vote for or against something.
Yeah, no, great points, all of it. And the oversight power is definitely an important one and offers a lot of protections for consumers and patients alike.
Yeah, because ultimately it is the legislative branch that funds all of the activities of the agency, except in a few cases where they've unfortunately dealt themselves out of appropriations, and that's a separate issue for a separate talk. But for the most part, uh, Congress does do the appropriations work. And if they would do their work and if they would do their appropriations correctly, then there would be opportunities to correct some of these problems. But again, it does require a lot of work. It requires a lot of member time, a lot of staff time, but that's the job. That's why we were there. That's why I was there. That's why Congress is there to, especially on the House side, they're the closest contact the people have with the federal government. And if the federal government is going to take over every jot and tittle of drug pricing, then it's really incumbent upon the member to be certain that that's not harmful to their constituents.